how the rest of you feel about this morning. I'm hovering between enthusiasm and dying to get on and do a bit of work and have a plan and all that, and actually offering everybody here a hug, and are you kidding me kind of expression. So I'm not sure. I'm between these two elements of cynicism and enthusiasm. Although I have to say I do come from a background where I always think the glass is half full, and I'm going to go with that. That's the way we have to grab these opportunities and make them work. I do think that the minister that's currently in charge has a great task ahead of him, and I wish him every success in that. And unless he has the attributes that are being discussed here today, number one, and which I firmly believe myself, you've got to have your customer and your patient at the centre of everything you do. And if it's good for the customer, it'll be good for you and for the whole society. So with that said, I'm not going to talk any more about that. I'd like to say we have interesting speakers coming up. I'm looking forward to hearing what they have to say, and we're going to have a panel discussion after that. Let me first introduce our first speaker, who's Tim McKeown. Tim is Director of Strategy with VHI. Tim has been responsible for facilitating the development of VHI's overall corporate strategy, leading strategic transformation programs, and identifying key opportunities to support corporate development and innovation. A key element of his role is the development of plans to address the projected future increased demands, which from this morning's conversation will be very interesting, in the healthcare in Ireland, as well as ensuring VHI's long-term sustainability. Since joining VHI, Tim has had numerous different roles. Particularly, he was Director of Product and Business Development, Head of Diversified Business, and CEO of VHI Swift Care Clinics. Prior to this, he worked in Belgium for 10 years in the European Commission, as well as the private sector. He has various qualifications, which I'm not going to go into everybody's qualifications, if that's okay. Without further ado, I'd like to welcome Tim to the podium.
Thank you very much, Donal, and thank you to Bill and the team for the opportunity to speak. I'm going to cover, if I can figure out how this clicker thing here works. We were shown earlier, and voila. Three main things really is just to talk very quickly about some of the highlights that we're seeing and some of the emerging trends that we're seeing in the PMI market, and how these are sort of the impact and the potential for these to impact both providers in the public and private space. Then to talk about some of the insurance side innovations, and specifically how the current rules and market rules either commercially incent insurers to innovate or otherwise. And then lastly, as we look at the market and as we talk to people, payers and providers in other countries, what are the likely future trends that have the potential to drive innovation in our space? So I'm going to skip over. I assume most people here know what VHI is and what we're about on our own innovation journey. So I'm going to skip on just to talk a little bit about the market that we're operating in. I mean, I think the first thing to say is that the market has been pretty resilient during the financial crisis. From about 2008 to 2014, the market fell about 12% from peak to trough, which is a big fall. But if you consider, you have conversations with guys around town who are working in other financial services, they're talking about 30, 40, 50% retrenchment. So we're very lucky that we work in a sector where what we sell and what we offer to our customers is really valued. And it was right up there during the financial crisis with food and shelter in terms of the items that people were not prepared to let go when they were reconfiguring their household budgets. So after 4 years of the market going this way, it's kind of stabilized in 2015. And there's really two big things that are going on here. First is some regulatory initiatives to stabilize the market. And then, of course, growth is returning to the economy and the employment sector is starting to expand. So in 2005, in the first half of 2015, the government brought in sort of age-related penalties so that if you stayed out of the market up to 35, once you joined the market, you then had a loading which increased each year subsequent. So that brought about 95,000 new people into the market for the first time. But since that initiative, which the deadline was April in 2015, growth has been very anemic in the market. In the second half of 2015, there's only 3,000 new people joined the market. If you look at the first half of 2016, there's about 11,000 new people have joined the market, and that's only about 0.5% growth. So whilst the market has stabilized, it's still a very fragile recovery. And I'm not trying to quote all these buzzwords from the election, but our market is still very, very stabilized, but still very fragile. And just to talk about, three highlights in terms of things that are sort of destabilizing and support and underpinning that fragility, and they're really all around affordability. I mean, the first is around market aging. So whilst the overall PMI market fell from peak to trough by 12%, people between 18 and 50, so that younger segment of the market, dropped by 23%. And the result is that there was a much larger increase then in people over 50. And that's critically important for the sustainability of our market, because I think it was in the Pat McLaughlin report when he was looking at the cost drivers of health insurance, aging contributes about 3% per year in terms of claims inflation. So as the market ages, the price is going up, and that's driving affordability pressures. The second is this whole public hospital space. I mean, if you take, there's about 2 billion of claims paid out by private insurers. About 700 of that is, 700 of that I've read in reports, is now going to public hospitals. And there are two things that are driving that. I mean, first of all, there are more and more people buying public hospital products, public hospital-only products, which provide little or no access to private facilities. So if you take those 95,000 people who joined the market last year for the first time, 75% of those people bought products that provided primarily access to public hospitals. The second big driver is the public hospital charges and the changes to the rules. I mean, previously, if a private patient turned up at a public hospital, they were charged the full rate if they occupied one of the designated private beds, which absolutely makes sense. But changes in those rules now mean that if a private patient turns up at a public hospital and doesn't get a private bed but is in a public ward, they're still being levied about €800 a night. We, the industry and VHI, pointed this out, the inflationary nature of this to government at the time. Government thought that it was going to generate probably about 30 to 40 million per annum. Industry reckoned that was going to be closer to 100 million, and I've read some commentators recently suggest that it could be as high as 150 million. So this is money that is 150 million, has to be funded from somewhere, and it's driving the affordability issue. And if you take those affordability, so if you take aging and other dynamics in the market that are driving the cost of insurance up, what we're starting to see is more and more benefit downgrading. And just to give you a sense of how that's playing out in the market. So this is, I suppose, our best attempt to try and look at how the market has evolved. So if you think back sort of 10 years ago, most products in the market would pretty much provide full cover to most private hospitals. That's now changing. So you now have product excesses. So back in 2005, maybe 200 people had a product excess. That's gone up fivefold now to over 1 million people. And not only that, but the value of those excesses is increasing. So some products now have excesses where you have €600 per claim. And I've just pointed out there on the right-hand side where that sort of trajectory was going in the States. And this is some work that the Kaiser Foundation did, which looked at the average deductible on employer-paid schemes. So these aren't the schemes that people buy in the exchanges. These are employer-paid schemes. And that's almost tripled over about a 10-year time horizon. So here we have customers who are now starting to have to pay more and more out of pocket for their care, and they're starting to make decisions about whether they need to get care or where they get their care from. There's also a big growth in network products, and these are effectively products which limit the choice of facilities where customers can go. Previously, most of the network products 10 years ago were between the high-tech hospitals and everything else, and then the public hospitals. There's now more restricted networks coming into products, and these are people trying to manage the affordability issue, try to bring down the price of their premium by either co-pays, benefits, or through these public hospital plans, where there's now about 200,000 people in the market have bought a public hospital-only plan. So that's just the market and a quick highlight. Really to talk now about some of the, how insurers are innovating in the market. I mean, like any market, the degree of innovation that takes place and the type of innovation that takes place is very much dependent on the commercial incentives and the commercial rewards. So I wanted to just talk about, first of all, how the market rules that we operate within incentivize or otherwise innovation. So there's been a lot of calls this morning about the need to address this tsunami that's coming down the line in terms of the projected increase in demand, and that insurers and providers need to work together more collaboratively, and policymakers, to find new solutions to meet this projected increase in demand in a far more cost-effective way. But the reality in the market that we operate is that all the commercial incentives are about selecting the non-claimants, the good risks in the market, not about managing the healthcare needs of older and sicker customers more cost-effectively. So just to give about a 30-second view of the rules that underpin the market, and about 30 seconds is all I'll have before I send people to sleep. But we operate in a community-rated market where the principle is everyone pays the same price for the same product, irrespective of age and gender and health status. There's a minimum set of benefits that have to be included in all products, and insurers can't refuse or decline cover. And that's underpinned then by a sort of a risk-sharing pool that sits in the middle. So what this demonstrates that, if you take the market average premium at about €1,100, and then you then look at what insurers have to pay out in claims for each age band. So that's made up of a number of things. First of all, the contribution that each policy makes into a central risk-sharing fund, the average claims cost for that age, and then what insurers get back out of that risk fund in terms of credits because of their older and sicker customers. You can make about €300 on a 30 to 39-year-old, and you can lose over about €1,200 for an 80-year-old. And that's just a simple sort of illustration to show that you need to do a hell of a lot of healthcare innovation in order to bridge that gap. So not surprisingly, that the way that the market is set up, the rules of the game are very much incentivizing insurers to identify strategies to select the healthy customers rather than to manage the healthcare needs of their customers more cost effectively. Just to give a sense of some of the examples of the insurance side innovations, a lot of these have been targeted at that younger segment in terms of things like online video GPs, mother and baby, then services for corporates and EAPs. We've also recently started looking at things like the fertility treatment, vision care, second advice service for doctors. We've also dipped our toe really in the provision space, but compared to our peers in other markets, we've taken very small tentative steps here. So we've looked at bringing innovations in terms of urgent care, where we sought to establish through the Swift Care clinics something that sat between primary care and acute hospitals, so that people who were turning up at A&Es could be treated in the community. We've also looked at innovation around the home care space, where we looked to, and also other insurers have similar services in this space, where we enable patients to continue their treatment after an acute episode in hospital at home. We've also then started to look at health outcomes, both in terms of asking our customers how their experience was through the care system, and also then working with providers to collect a number of clinical indicators. So that's really where the innovation is taking place at the moment. To talk about the future, and as we look at the market, and as we've spoken to people and insurers and providers in other markets, the same themes in terms of what's going to drive innovation in the future keep coming up. I'm not going to talk through all of these, but maybe just to focus in on the one that has certainly been referred to several times this morning in terms of the demand tsunami that's coming down the line, and also the role that regulation and indeed reimbursement has played in other markets in terms of driving innovation. So this is the tsunami, and I'm not going to tell people what they already know, but it's worth taking a minute to stand back, because sometimes we talk about the demographic time bomb as if it's something that's going to happen in many years' time. This is happening before our eyes at the moment, and the speed at which this is happening and is going to accelerate is what the real issue is. And just to give you an example, if you take the 20 years from 96 to 2016, there are about 200,000 additional 65-year-olds who entered the market. If you look at the 20 years that is going from 2006 to 2026, that's going to double to close on 400,000. And that's going to get particularly weighted at the 80-year-old end of the market, where we all know healthcare costs are the steepest. So if you take that aging, so whilst Ireland is going to remain one of the youngest population, if not the youngest population in Europe, we are going to do aging on speed. We are going to age, we're going to get to where Germany, Italy, and France are, which took them generations to get there. We're going to get there in 1 generation. And that really is the burning bridge for that we need to do something. So when people talk about the time bomb ticking, that time bomb is actually exploding in front of us. And our market and our industry is probably going to see that before the rest of the country, because the average age in the health insurance market is now in the early 40s. So if you take that aging and you add what everybody knows is happening in terms of the incidence and complexity of diseases, we're going to have a hell of a lot more people walking around living for a lot longer with a lot more complex comorbidities. So we've tried to, I suppose, project what that might look like, and this is where maybe to go back to what Donal was saying about the dilemma that we're facing. There's a clear need that we have to do something, but it's the cost of doing something which is the real problem. What we've tried to do is to project as best we can. If you take that aging, look at historical trends, take the projected future aging and what's happening with illnesses, we're going to see our claims line across the market go up by about 80%. And I can understand that there's many people, and we get visits every other week from healthcare providers from other markets who are looking to come into the market and get a piece of this action. That all sounds great, and we can do all our business plans and our expansion plans. But the problem then is, how is society or how is the market going to be able to pay for all of this new care through the existing care model? So this is us looking at, if you were to take the projected demand that's coming down the line, if you were to put it through the existing care model, which is primarily built around acute hospitals, and then try to cost that out, this is the bill that we're looking at. And very quickly you come to the conclusion that the market is not going to be able to pay for this future demand. And this is a fairly crappy attempt to try and illustrate that in a graph here, but over the past, and I'm not even going to try and get this clicker to work because here we go. So in the past, if you go back to sort of the 2000s when the demand line started to increase, it was kind of tracking with where wages were going at the time. But even, the most optimistic view of where disposable incomes are going, there is no way that the claims cost is going to be able to continue to track into the future. So our view, and I think it's a view shared by many other people in this room, is that trying to meet this projected demand through the current care model is not going to work, and we're going to have to do something different. So the obvious question, and sorry, just to illustrate that in terms of an affordability spiral, and this is kind of something that we're already seeing. So you see healthcare costs increasing, and don't forget, we're working in a voluntary market. This isn't a compulsory market. People have the choice of whether or not they buy private health insurance. So as they see costs rising, you see younger members who are either exiting or downgrading the market. And that then it pushes the age up, pushes the claims up, and you get into this spiral. And we're starting to see that spiral to some extent. And if we continue to try and deliver the care through the existing model, that spiral is going to start spinning faster and faster. So how do we, I suppose, address this? And there's other people who will speak far more authoritatively than I in terms of the solutions, the delivery solutions. But we've been looking at sort of models of care in other markets that have had to meet this projected demand and had to confront this sooner than we've had to, and also pockets of innovation in the Irish health system. And there's a number of things that sort of stand out. There's one particular model that I saw which really struck me was there was a state in the US, or a small sort of health system in the US, and they were able to deliver the healthcare needs of their population, which was similar to the VHI book, both in terms of age and in health status, using a third less acute hospital beds than VHI. So Jesus, you start to have a look at this and say there must be something going on here. And as you get underneath it, they're able to do this primarily with doing two things. I mean, first of all, reducing the number of admissions into acute hospitals and reducing the length of stay, and then treating an awful lot of the conditions that we're treating in an acute hospital in a different setting, either in an ambulatory care setting, a step down, using telehealth, or in other community and outreach centres. And we've kind of seen there's probably 4 big things that we have seen in terms of how other markets have remodeled their care. And a lot of this will be familiar to people here. The first is sort of using standardized care processes, and we heard Professor Brennan and Charles Bogosta from UPMC talking about how you can use data and technology as well to improve care. A much broader use of healthcare infrastructure beyond the acute hospital, so things like ambulatory care, step-down facilities, digital access to digital platforms, community infrastructure, and so on. We also see different types of resource models being used. Particularly in that hospital setting, there seemed to be a lot greater use of specialist consultants, generalist consultants, or hospitalists that I've heard them call, who are sitting at the front door of the hospital deciding whether or not somebody needs to be admitted. And if they are admitted, what happens to them when they're in the hospital? So this model of care is working alongside the existing consultants and clinical professionals in the hospital. And we saw a very good example of it based down in Kilkenny, where they've set up their medical assessment unit. And their whole ethos in Kilkenny, which really struck me, is that they assess people in order to discharge them home rather than admit them in order to assess them. And that's what these new models are developing and that these new resource models are supporting. And then within the hospitals, care coordinators who are both coordinating all of the different moving parts of the care within the hospital, and then most importantly, when the patient is discharged, providing support to the team back in the community to manage the patient and provide those decision-making supports. And the last then, which you always hear talked about, is about reimbursement and outcomes measurement. So they're the sort of models that we have, or the principles that we have seen in terms of models that seem to make sense. That requires a significant rewiring of our current system. It also requires us to do it in a way which is cost sustainable. So the innovation that's required to move to this, whilst there's loads of models that exist and there's loads of blueprints that exist, getting there is very, I wouldn't underestimate the complexity of getting there. The second potential driver of innovation in the market is around the whole area of regulation. And as we've seen in other markets, regulation and reimbursement rules have been real drivers of innovation. So in the States, insurers and providers will tell you that the DRG system used by Medicare and Medicaid has really forced providers and insurers to deliver care in a far more cost-effective manner. We've seen already that the incentives in our market don't really incentivize, the commercial rewards aren't there for insurers to manage the healthcare of their customers more cost effectively. But one possible opportunity that we could sort of explore for innovation is we have this risk sharing pool, which you will have heard many people talk about. And that's effectively every insurance person insured on average pays in about, well, not on average, but most policies, there's about €400, all goes into this sort of central claim sharing kitty. And that is used then, it's distributed back to insurers to cover the cost of high-cost claimants. And insurers take money out of that system through two models. The first is age and gender. So for every 80-year-old an insurer has, they get a check for, I think it's about 4,000 odd euros. That doesn't matter if I could have a very healthy 80-year-old and Donal has a very sick 80-year-old on his books that's costing potentially 80,000 euros. We both get the same check. There's also an amount of money that comes out of that pool, which is really it's a proxy for health status. So every night somebody is in hospital, there's I think it's about 400 for an inpatient, and it's a much smaller amount for outpatient. Again, it doesn't matter if you're in hospital with an appendectomy or a complex cardiac procedure, you still get the same check for 400 euros per night. So one opportunity, and we've seen this in Germany, so how this fund could potentially be, a slice of this fund could be used for insurers and providers to collaborate to support innovation, is around the whole area of managing sort of chronic illnesses. And we've seen in Germany, for instance, they started off about 15 years ago with a very similar, and I'll be finishing up now in about, this is my last slide, with a very similar system to ours, where the incentives were all around managing selecting good risk. But they have gradually changed their model. And they first of all incentivized insurers to create chronic disease registers of their customers. Insurers were incentivized to work with providers to develop more innovative programs to manage and design and deliver innovative programs to manage the care of these chronically ill people. So the point now is that you have insurers who are actually competing not to select good risk, but the commercial returns are there to manage the healthcare needs of their sick and ill customers in a more cost-effective way. To the point where, and maybe Professor Jurison will talk about this when he talks about, we've seen in the Netherlands, the risk equalization provides such strong incentives to manage healthcare more innovatively that one insurer is out advertising to recruit diabetic patients. That is unheard of, would be unheard of in our market. So lastly, just to sum up, I'll leave you with three thoughts. The first is the market has stabilized. but it's quite fragile. And whilst some of the initiatives that government have taken to stabilise the market are to be welcomed, more needs to be done to manage costs, particularly around the public hospitals, and potentially extending the age discounts for younger customers and to attract more younger customers into the market. It's clear that the current model is not sustainable and will have to change, but that's going to require a significant rewiring of a lot of business models on the insurance side and on the provider side, because we cannot do this innovation unless it's done in a cost-neutral way. We cannot change, the model has to be changed in a way that is going to be cost-neutral. The money simply isn't out there in order to keep adding, layering on top and on top and on top. And the last is there are some near-term opportunities to potentially collaborate around developing chronic disease and innovative chronic disease management programs that could potentially be funded through the existing risk-sharing scheme. Thank you very much.